Hello, everyone, and welcome to this symposium entitled MCI, Diagnosis, Disclosure, and Management. My name is Kristian Steen Frederiksen, and I'm a senior consultant neurologist at the Danish Dementia Research Center in Copenhagen, Denmark, and I'll be chairing this symposium and giving the first talk. So I'd just like to start by thanking the organizers of Alzheimer Europe 2021 for organizing this symposium, which is a joint symposium between the European Academy of Neurology and the European Alzheimer's Disease Consortium. And I really hope that this joint symposium will help to further strengthen the collaborations between all our three organizations. I think the topic of this symposium is very pertinent. Namely patients with MCI and how we best diagnose and manage these patients. And I would very much like Alzheimer Europe for allowing us to address these issues. I'm joined here today by three of my excellent colleagues within the field of dementia, Professor Lutz Frölich and Professor Professor Frank Jessen, who are also the co-chairs of the EADC, and Professor Giovanni Frisoni, who is an active member of both organizations. And I should also say that my own role is that I'm the co-chair of the European Academy of Neurology Scientific Panel on Dementia and Cognitive Disorders. So just a few words on the outline of this symposium. We will have four talks today, and then we will have a joint Q&A session at the end when everyone has given their talks. So please provide any questions you have in the chat function in Zoom, and then I will pass these questions on to our speakers, and we will hopefully have a lively discussion. So we have a mixture of pre-recorded and live presentations today, and I think that with no further ado, I think we will jump to the first talk given by myself.
The title of my talk in this joint symposium is Disclosing a Difficult Diagnosis, Practical for the Disclosure of MCI. So my talk will be centered around a recent position statement by the European Academy of Neurology and European Alzheimer's Disease Consortium, published in 2020 in European Journal of Neurology, on diagnostic disclosure, biomarker counseling and management of patients with mild cognitive impairment. The paper was built around four areas, and I will be covering two of them, disclosing a syndrome diagnosis of MCI and pre-biomarker sampling counseling. Some of my fellow presenters in this symposium will touch upon the other areas. So I think that for most of you, the concept of mild cognitive impairment will be familiar, but I would just like to touch upon a few areas related to the diagnostic entity of mild cognitive impairment that stimulated the position paper or the production of the position paper, and that may give clinicians some issues in disclosing the diagnosis of MCI. So as you will know, the first diagnostic criteria for Alzheimer's disease were published in 1984. And basically, they equated Alzheimer's disease to the dementia stage of the disease. Now, taken to this extreme, this of course will mean that up until the time the patient crosses the dementia threshold, the patient would not be able to be diagnosed with Alzheimer's disease. I think that the authors of the 1984 paper was aware of this, and that the diagnostic criteria did not cover the whole phase of the disease, but they were uncomfortable going beyond the dementia stage due to the knowledge at the present time. But it's obvious that there is a transitional state from having no dementia to having dementia, and this transitional state is to some degree captured with the concept of mild cognitive impairment. And indeed, the first diagnostic criteria, the so-called Peterson criteria, published in the mid-1990s, were specifically developed to capture this transitional phase in patients who would later on go on to develop Alzheimer's disease. So in other words, patients that were diagnosed with mild cognitive impairment were at a higher risk of developing Alzheimer's disease, or perhaps even destined to develop Alzheimer's disease. This model, of course, also extends to other neurodegenerative diseases. So on this slide, you will see some data showing that if you have amnestic MCI, risk of progressing to Alzheimer's disease is relatively high. And if you do not have amnestic MCI but another non-amnestic profile, the risk is lower. But for both those that have amnestic MCI, the risk of progressing to Alzheimer's disease is not 100%, at least not over a certain number of years. And likewise, if you do not have amnestic MCI, there's also a risk of progressing to Alzheimer's disease. This, of course, has to do with the fact that MCI may be due to other neurodegenerative disorders and indeed other diseases, so that it is important to keep in mind what the underlying disease causing the syndrome of MCI is. So in other words, MCI is a syndrome such as dementia, and diagnostic procedures should aim at finding the underlying cause. This stimulated the development of other diagnostic criteria that were more broad and captured the full palette of the possible underlying causes of MCI, for example, such as the Wienblad criteria for MCI published in 2004. This is data showing some of the possible outcomes of having MCI and some of the different rates that have been reported in different studies looking at whether patients may convert to normal or progress to dementia. As you will see, there's a high degree of heterogeneity, both with regards to the rates of reversion to normal as well as progression to dementia between the different studies here, following up patients for different amounts of years. And this, of course, has to do with the population and setting that the patients were recruited from. It also has to do with the fact that the underlying cause is maybe very heterogeneous. It may also have to do with the diagnostic criteria used and also the methods for determining the diagnosis. So was this, for example, done retrospectively or prospective? Were cutoffs on neuropsychological testing used to define MCI, or was this done clinically by a physician, for example? The criteria for MCI has also further evolved and included biomarkers to better sort of capture this prodromal or pre-dementia stage of neurodegenerative diseases such as MCI, and to make such as MCI due to Alzheimer's disease, to make the criteria more specific and better at predicting the risk of progression. I will not go into detail with these criteria any further. So from a clinician seeing patients with MCI, I think that most will probably see a wide variety of patients with MCI having many underlying causes ranging from Alzheimer's disease, which is a neurodegenerative, progressive, and not curable disease, to, for example, patients having depression or maybe thyroid disease that can also lead to cognitive impairment. And this heterogeneity is important to keep in mind, and was also one of the reasons for the first recommendation in the paper, and that is that at the initial interview with the patient should be informed about the potential implications of starting diagnostic workup for cognitive impairment. Because we may discover that the patient has an incurable brain disorder such as Alzheimer's disease, and this may be unwanted information, but of course, on the other hand, we might also discover that the patient has a treatable condition, and this is of course also important to convey to the patient. It's also important to understand why the patient has sought out medical attention. Is this for reassurance that everything is okay, and that is that information to the contrary may be unwanted? The patient will oftentimes feel that something has changed and may rightfully want to know why. The caregiver may also be concerned and not really the patient. And it may also be that the patient is only interested in knowing whether or not whether or not he or she has Alzheimer's disease. And this led to the second recommendation, and that is that the motives and reasons for seeking medical attention and the ability of the patient to comprehend the information should be taken into account when informing the patient about diagnosis, prognosis, and post-diagnostic support. It is sometimes also debated whether a diagnosis of MCI should be disclosed at all. One reason might be to argue for not disclosing is that it may lead to unnecessary concern or stress, because we might diagnose a not treatable or not curable serious brain disorder and in a very early stage, and maybe the patient is better off not knowing this. It may indeed be unwanted information, and it may also have implications beyond the medical arena with regards to insurance or employment, for example. We do not have data from patients with mild cognitive impairment to suggest whether or not patients want to know about this diagnosis, but we do have for dementia, both in the general population and in patients with cognitive impairment. And this is data from a meta-analysis showing that the majority of patients wanted to know whether or not they had dementia, but that a significant minority did not wish to know this. And this is, of course, also important to keep in mind. And this was also one of the reasons why we formulated the next recommendation, and that was that a syndrome diagnosis of MCI should always be disclosed to a patient, except when the patient explicitly wishes not to be informed. And this is, of course, trying to balance the right to know versus the right not to know. And also the next recommendation was that the diagnostic disclosure should always be accompanied by a plan for follow-up and post-diagnostic support, so that we do not only leave the patient with a diagnosis, but also what the future may hold and what support, try to empower the patient going forward from this stage. This is data showing that, at least with regards to anxiety and depression, it seems to be safe to disclose a diagnosis of MCI, in this instance equating to very mild dementia, where there was even a decrease in symptomatology following disclosure of a very mild dementia diagnosis. Again, data on disclosure, this time amyloid status. This is data in healthy elderly persons, so in patients without or persons without cognitive impairment, showing that there was no increase in anxiety or depression following disclosure of a positive or a negative amyloid scan in healthy controls. Despite this, the fact, it is of course very important to inform the patients prior to biomarker counseling, because we here very specifically will be able to determine whether or not the patient has a neurodegenerative disorder. And this led to these two recommendations on pre-biomarker sampling counseling, and that is that this should always be undertaken prior to biomarker studies, and in order to enable the patient to make an informed and an autonomous decision. And this should be done in a balanced and individualized way, informing about potential risks and benefits, limitations, as well as alternatives, because this is of course important for the choice to be really a choice. So this might include, for example, extensive follow-up or very close follow-up instead of doing the biomarker sampling. Lastly, just like to touch a bit upon how to disclose an MCI diagnosis. This is data from a European survey of EADC centers, asking physicians what terms they use when disclosing a diagnosis of MCI. And as you will see, many physicians use the term mild cognitive impairment, and most try to avoid any mention of the word dementia. And indeed, this led to the formulation that of a recommendation in the position statement to avoid terms referring to a dementia when disclosing an MCI diagnosis, because it is not dementia and not all patients will progress to dementia. Alternatives might be to use the term mild cognitive impairment or memory or thinking problems of uncertain origin. Of course, it's important that the explanation also touches upon the underlying cause, because this will have very many implications for diagnosis. And it might also be that for some underlying causes, let's say a patient diagnosed with depression that causes an MCI syndrome, it may be better to disclose the diagnosis of a depression and not MCI. And with those final words, I'd like to thank you for your attention.
So with the first talk over, we will move on to Professor Frank Jessen, who will be giving a talk on patient perception of biomarkers. Professor Jessen is a professor at the Department of Psychiatry at the University of Cologne and is associated with the German Center for Neurodegenerative Diseases. Frank, go ahead.
So thank you very much for setting up this symposium, and thank you, of course, Alzheimer Europe for making this possible. I will discuss patient perception of biomarker results, and I will present to you a specific study which we are doing. The PREDAT study. It's a study we are doing in collaboration with Mercè Boada from the Fundación ACE in Barcelona. And it's about basically the practical proceedings of what Kristian just presented. So these are my disclosures. Regarding the background, I think it's very clear for all of us that nowadays we have biomarkers which allow the identification of individuals who are at increased risk for Alzheimer's dementia in the future by measuring the typical Alzheimer's disease-related changes such as amyloid and tau and neurodegeneration. And this is done in clinical practice quite extensively and also, of course, in clinical studies. There are a number of studies looking at the disclosure of such information of biomarkers like amyloid PET, but also older studies looking at the genetic risk factor of ApoE or in healthy volunteers, so individuals who participate in studies on this matter do have no symptoms. And the general finding there is that there is no significant or no strong negative impact on the social well-being, on the psychological well-being and mental health. With regard to MCI, there is not so much literature around. There is some qualitative studies and one recent quantitative study, which I will quickly present in the very end of the study of the presentation, that indicates that the impact of biomarker disclosure in mild cognitive impairment can actually provide or result in a wide range of emotional reactions. The PREDAT study is funded within the ERANET Neuron program, and the aim of this study is to develop an empirically based framework for counseling and reporting of findings of predictive AD diagnostics, biomarkers in MCI patients. And I will present you some results of our empirical work project. It's a interdisciplinary program with also ethical medical ethicists and also lawyers or people who look at this topic from the point of view of law. And I will present to you here this study we did with patients. It's a mixed methods approach to investigate the expectation towards dementia risk prediction and the impact on quality of life and mental health in patients with MCI and their family members. We do that at 2 sites in Spain and Germany. And the eventual aim is to prepare handouts and information for this counseling process. This is a study design. So we enrolled 76 patients with amnestic MCI and 76 relatives at 2 sites. And we did a very standardized counseling on CSF biomarker-based early detection of Alzheimer's disease and the Alzheimer's dementia risk prediction. So very similar to what Kristian had just presented. And then we did a standardized reporting of the individual AD biomarker findings and counseling about or information about the risk of dementia. So in detail, so this is in German, but I walk you through this. So the individuals were basically memory clinic patients who went through the standard MCI diagnostic procedure within the memory clinic. And at the stage where we would start talking about biomarkers, so after the establishment of the MCI diagnosis, they were enrolled in the study. And if they agreed to participate in the study, there was a baseline visit. And at this baseline visit, we did very intense and extended, rather standardized information or counseling on Alzheimer's disease, early Alzheimer's disease, MCI, biomarkers, capacity of biomarkers to predict risk, consequences from different outcomes of biomarker assessments, so like lifestyle effects and others, and a whole set of information, including handouts on the key components of this information. So after that, the patient and the caregiver had a few days to consider whether or not they want a lumbar puncture for biomarker assessment. So they were not randomized. If they want a lumbar puncture lumbar puncture for biomarker assessment, we did the lumbar puncture. And then as soon as we had the results, we did another visit together with the caregiver or the family member, and we explained the individual biomarker results, and we again explained everything related to this, so individual risk for progressing to dementia and things with considering lifestyle effects and preventive measures and all of this. And we had we had 3 visits, one week after this disclosure visit, and one 3 months later, and we are still working on the 12-month visit. So if the individual said, I don't want a CSF lumbar puncture, then we also performed a 1-week visit, the same visit, 1 week after this consultation, and another one at 3 months and at 12 months. So this is the design, and we assessed very many questionnaires on mental health, on expectations, on risk perception, and I will show you some examples of our results. So this is one piece of our counseling material. For example, this is how we counseled the patient. So our risk for dementia rates in MCI, we draw from the literature. So the overall risk for dementia in MCI cases, according to a very large meta-analysis by Mitchell et al., is around about 30 to 35%. This is what Kristian also just pointed out. And then we started this study before the ATN was really established. So we used the AN system, so amyloid and markers for neurodegeneration, which was used by Stephanie Voss in this 2015 meta-analysis in MCI patients, and she reported that if you are amyloid and tau, or this is wrong, A and N negative, so amyloid and neurodegeneration negative, your risk for dementia is below 10%. If you have either only amyloid and no neurodegeneration, or no amyloid but evidence for neurodegeneration, your risk is about 50%. And if you have the full Alzheimer's pattern of amyloid and neurodegeneration, the risk is 90%. And we use these, this is one example, we use a whole variety of material, but this is one example how we use these pictograms to explain what a number of 35, 10, or 50, or 90% means. So we use this before the CSF assessment, and then after the assessment with, of course, considering the individual results of the biomarkers. This is a sample. We had, enrolled 50 diets in Barcelona and 26 in Cologne. The mean age of the patient was 73. The family partners were slightly younger. There were a little fewer female patients and a little bit more female family partners. The mini-mental state on average in the MCI group was 26, rather high, many years of education. Around about half of the patients participating had a positive family history of dementia, and only a quarter of the family members. We had very low scores on the geriatric depression scale and general anxiety inventory, so there were no patients enrolled with clinically relevant depressive disorder or anxiety disorder. We measured the numeracy scale, which is a scale which measures the understanding of numbers with regard to risk communication. 60% actually participated in the CSF study, so agreed to have CSF sampling. 40% after counseling did not agree to CSF sampling, and these are the results. So we have the distribution, and we find we have 24 patients who actually have the full Alzheimer's profile, and 13 who are fully negative with regard to biomarkers in this study, and some in between. So these are the results of the GDS, so depressive symptoms. What you always see as baseline is before disclosing of the biomarker results, and then 3 months later. And what you can see is that we do not have any significant change in patients or family members in this GDS scale across the whole group. And when we look at the individual results of biomarkers, so the full Alzheimer's disease, A+, N+, or the intermediate cases, or the full negative cases in green, A-, N-, or no CSF, we see slight changes, but all of these are not significant. So we do not see any, in neither group, any significant effect on symptoms of depression. And we can say that the same is true for symptoms of anxiety. So we do not see, any significant change in symptoms of anxiety. There is a mild increase in some groups in anxiety in the patients, but this is all non-significant and not clinically meaningful or relevant. This is a satisfaction of life scale. This is a scale which measures basically how satisfied with life you are. And we can see here that there are no significant effects. There is some mild increase in the group which have fully negative biomarkers for Alzheimer's disease. There is a mild increase in satisfaction of life in this group. However, this is also not significant. This is all very stable. This is a questionnaire we designed ourselves on healthy lifestyle. So whether you eat well, whether you have physical activity, and all of these well-known lifestyle effects. And we thought that we would have effects on lifestyle, which are, for example, increasing because we did a lot of counseling on healthy lifestyle and what is useful for brain health. But contrary to our expectations, we saw in both groups a reduction in these lifestyle measures, which might be related to some still coping with the diagnostic procedure or other things. So it's not quite clear why we see that, but we see a decline, and we see that also in all different groups, particularly in those who have negative biomarker findings or not a very high risk for AD. They actually stop doing all the healthy lifestyle, whereas those who have some full AD pathology or no CSF obtained, they stay rather stable. But those other two groups seem to be somewhat relieved and stop doing all their efforts for brain health. I mean, this is of course not true, but this goes in this direction. And I think this is a very important result. This is how well did the patients and the caregivers actually perceive their individual risk, and how well did they remember that after 3 months. And these are the patients here. And what you can see is that even though these different groups receive very different information on their individual risk, depending on their biomarker profile, for example, the A+N+ received an information that they have a risk of 90% of having dementia. and after 3 months, they considered themselves as having a risk of only 40%. The group without CSF, they have an initial expectation of a risk of around about 35%. This is exactly what they are told before biomarker assessment at baseline, but then they consider their risk lower over time. But this is all not really significant. The family members, and this shows that our consultation worked, because those who have a family member who has a full Alzheimer's profile, the family member actually understands that the risk is not only just above 30, which was the reported risk without biomarker information, but strongly increases, not up to 90, but up to over 50. So this strongly goes up. And those who have negative biomarkers, so no evidence for Alzheimer's disease, that risk actually is estimated to go down. So these are the correct recalls of the communication of risk after 3 months with regard to the healthy family members, but the MCI patients were not really able to recapture their personally communicated risk 3 months after intense disclosure. So this is something we have to consider, that the memory impairment, which is of course characteristic for MCI, is really an issue with regard to disclosing complex information. This is one final slide I would like to show you from Jennifer Lingler from Pittsburgh. I think it's a very nice study, which is somewhat similar. They did a randomized controlled trial in 82 MCI patients and their caregivers to determine the effects of receiving amyloid PET results on understanding of and perceived efficacy to cope with MCI over 52 weeks. And what they found is that amyloid negative patients report a greater perceived ambiguity regarding the MCI diagnosis at follow-up. So they are still uncertain about what they have. And the authors interpret this in a way that the information that they do not have amyloid relieves this, but they still have MCI, and this still leads to uncertainty with regard to their own health condition. And in those who were amyloid positive, the authors observed moderate and sustained emotional distress in patients and caregivers in those who were amyloid positive. In agreement with our study, they did not see an increase in frank depressive symptoms, but increased emotional and sustained distress was observed in A beta positive and amyloid positive cases and their caregivers. So to summarize, according to our data, disclosure of biomarkers and Alzheimer's dementia prediction has no clinically relevant effects on psychiatric symptoms such as depression and anxiety, and life satisfaction in short term. And this is in a way in agreement with the study by Linkler, which was published last year. Counseling on secondary preventive effects on lifestyle factors did not have any short-term effects. In contrary, negative changes in lifestyle were observed in our study. The communication of the individual Alzheimer's dementia risks seemed to have no influence on the subjective dementia risk perception in MCI after 3 months. Among relatives, there was a significant correlation between the communicated risk and the risk perception. So the relatives basically recalled the correct information. Ambiguity regarding amyloid assessment in amyloid negative MCI cases and moderate sustained distress in amyloid positive MCI cases was observed after amyloid disclosure. So this is from the study of Linkler. Thank you very much for your attention.
Thank you very much, Frank, for this great presentation on patient perception of biomarker results. And it's good to see that there's some inroads in terms of providing evidence for this important part of caring for patients with MCI. We will move on to the next talk, but just a reminder to all the participants listening to let us have any questions that you have on the chat, and then we'll address these at the end in the joint Q&A. Now I will pass the word on to Professor Giovanni Frisoni. Professor Giovanni Frisoni is a professor at the Memory Clinic at the Faculty of Medicine at Geneva University Hospital in Switzerland. Welcome, Giovanni, and the floor is yours.
Okay, today I will tell you, I will entertain you with some ideas on the diagnostic challenges that we had when we use biomarkers for the diagnosis of early Alzheimer's disease. You heard already a lot from Kristian and Frank. Let me try and expand a little bit. These are my disclosures, and just in case, this is my green pass. Swiss green pass, very reliable. I will address these 4 points. I will start with by discussing the 2 major frameworks that are available today to diagnose Alzheimer's: the ATN framework and IWG 20.1. I will move on discussing all the array of biomarkers that we have available, wet on CSF and dry on imaging for the clinical diagnosis. We have a number of them that we can choose from. But there's a problem. How do we use them efficiently? And I will expand a little bit on a European study that we're carrying out together with my colleagues who are in this session, and a few words on the future if we have time. Now, this is a slide summarizing the dynamic of the clinical criteria for Alzheimer's disease since 1984. As you can see, every couple of years on average, since 2007, the original criteria date back to 1984, and we've been using them for 25 years. Then starting from 2007, there's been 1 revision every other year, more or less, until 2018, NIA-AA. And the way that's with the road that's been walked has been enormous. We started in 1984 by saying that Alzheimer's was a clinical syndrome, and we just had to exclude secondary causes, meningioma, normal pressure hydrocephalus, and whatnot. In 2018, Cliff Jack said, okay, forget about the clinic. Don't bother about asking about doing mini-mental neuropsychological assessment, 1 hour history collection. Just do amyloid, collect an amyloid marker, a tau marker. If a patient is positive on both, he has Alzheimer's disease, period. If the patient has just amyloidosis, he's on the Alzheimer's continuum. He doesn't really have Alzheimer's disease. He has Alzheimer's continuum, which is a kind way to say, okay, you're going to become demented, but not yet. I have some issues with when using these criteria in the clinic with my patients, because the narrative, this narrative, the scientific narrative, is completely decoupled with the narrative of patients, with the narrative of society. To the left, you have the narrative, the ATN narrative. You have an old person who is able to climb the north face of Eiger, but he's amyloid positive. You're going to call this man Alzheimer's continuum. If he has a tau, he has Alzheimer's disease. This is the scientific narrative. But this is in B, this is the social narrative. The social narrative of Alzheimer's is a disease of memory, progressive and severely disabling. If we use the same words as scientists and clinicians with persons who have a different narrative we elicit completely different images, future notions and ideas in the patients that we're talking to. So I believe that these criteria are not suited to be used in the clinic. Actually, this is what they say. They suggest that they should be used only in research. But we very well know that once new ideas are put forward, the clinicians are ready to uptake them. The EAN, CDS, ADA criteria were research criteria at the beginning, but they've been used in the clinic for 35 years. The same thing has happened to the NIA-AA criteria. They should be used in research, but many people are using them in the clinic. One of our colleagues recently told me, well, you know, we should update. We're still using NIA-AA criteria, the old one in 2011, but we will shortly update to NIA because, you know, you want to be on top of things. You do not want to give the message to your patients that you are not updated, that you do not use the very latest tools, the very latest ideas to treat them. So the NIA criteria, the ATN framework is used in the clinic, even if it shouldn't. But we have a solution. There's IWG criteria from published by Bruno Dubois and others in this year, where the clinic is back. You can call a patient Alzheimer's disease if there's amyloid, if there's tau, but also in the presence of a clinical syndrome, of a hippocampal time or an atypical syndrome, but there must be the clinic. There must be cognitive impairment, not necessarily dementia, but there must be cognitive impairment. And these are criteria that allow to realign our narrative as scientists and clinicians with the narrative of society, of patients and the society. Then, okay, we know what criteria to use. How do we figure out that someone has amyloidosis, tauopathy, and neurodegeneration? Well, we have a number of techniques. We have structural MR, with which we can study the neurodegeneration. We have glucose PET, which is even more sensitive to neurodegeneration. We have DAT scan, which is sensitive to local neurodegeneration of the striatonigral system. We have amyloid PET, which is sensitive to amyloidosis. We have tau PET, which is sensitive to tau deposition. And we have CSF, which allows to test both amyloidosis with a beta 40/42 ratio, with phospho-tau, and with neurofilament light. And this is what you find in a healthy person. A person with Alzheimer's disease, even in the prodromal stage, even if MMSE is 24, even if MMSE is 28 or 9 or 29, this is the pattern that you will see. You will find some medial temporal atrophy, not always, but 60% of the 70% of the times this is what you will find. 80% of the times you will find temporal parietal hypometabolism. That scan will be normal. You will find amyloid PET all the time. If the patient has genuine Alzheimer's disease, tau PET is positive, and it affects the medial temporal regions, the entorhinal cortex, but usually also the lateral temporal, and sometimes already the frontal and parietal cortex. And the CSF will have the usual pattern with the decreased ratio, beta 40/42 ratio, and increased tau and increased neurofilament light. So this is, if you use the whole panel of biomarkers that are currently available, you will be able to diagnose Alzheimer's disease with a very, very high accuracy. It's basically in vivo neuropathology. If you have a patient with frontotemporal dementia, the pattern is different. I do not have to go into the details, but as you can see, there's a severe atrophy, oftentimes severe medial temporal atrophy. You have frontal hypometabolism, and so on and so forth. Dementia with Lewy bodies, the pattern is again different. Here, it's DAT scan is the key finding, where you find reduction of the tracer uptake in the striatum. But oftentimes you have also an FDG PET scan, which is reminding an Alzheimer's pattern, where you also have occipital hypometabolism. Amyloid is also positive, oftentimes, not always, but it's often positive. And this is yet another clinical, this is another combination of biomarkers, late, limbic predominant, age-associated TDP-43 encephalopathy, where you have very severe bilateral atrophy, medial temporal atrophy, and a number of other findings that I don't have the time to go into the details. But what I want to tell you here is that if you use the whole panel, you will be able to do a very, very accurate diagnosis in the vast majority, almost all the times in all your patients. Of course, this is not terribly cost effective because it's going to cost a lot of money. In some places, tau PET is not available. It's still a research. It's still a research exam. So in Europe, we are currently developing, this is a work in progress. It's not completed yet. Together with a number of scientific societies, neuropsychology, neurology, nuclear medicine, and so on, you can read them all. We are developing an algorithm for the efficient and cost-effective use of biomarkers in the clinic. And as you can see, Kristian Frederiksen and Lutz Frölich and Frank Jessen, they're all involved, as well as Alzheimer Europe and some others as well. And this is how the algorithm will look like. This is not the final algorithm, but this is let me give you a perception of how it will look like. You start with wave 0, the usual assessment. In wave 1, you define a clinical syndrome. For instance, amnestic cognitive impairment and disproportionate medial temporal atrophy. This is typical AD. You suspect AD pathology, you go first for CSF. Other possibility, you have a predominant non-amnestic visual spatial deficit and consistent focal atrophy in posterior cortical. You suspect this is a posterior cortical atrophy syndrome. You suspect atypical AD, you still go for CSF. And then you have a number of others syndrome, and for each syndrome, you have the biomarker, a suggested first wave biomarker. We are working now to the second wave because you have the biomarker can be positive, can be negative, can be doubtful. What do you do in that case? What's the second line biomarker? This is what we're working on. We're currently working on. In the future, there will be blood biomarkers. We all know about it. I don't have time to go into the details. There will be biomarkers that will allow to screen the presence of neurodegenerative changes, such as neurofilament light in plasma. There will be blood biomarkers that will allow to screen for Alzheimer's pathology, such as plasma phospho-tau 217. So to conclude, the take-home messages is that number one, the diagnosis of cognitive complaint with biomarkers was done simply on the basis of the wish to know, because it's always good to know. In the next few years, this is something I've not addressed, but there will be etiological treatments. There will be monoclonal antibodies. It may be aducanumab, it may be others, but there will be. The door is open. Number two, the use of biomarkers in the clinic should follow a rational and cost-effective algorithms. And we're developing one in Europe that may be able to help you. Number three, that the availability of blood biomarkers will soon change the way that we currently use imaging and CSF biomarkers, but let's start using effectively and efficiently the currently available biomarkers, because on top of those, we will, on top of efficient use of the current biomarkers, we will be able to implant, to use efficiently blood biomarkers. And I wish to thank you for your attention.
Thank you very much, Giovanni, for this interesting talk on how we may be better at applying the biomarkers that we have for the sake of our patients, as well as for prioritizing the resources that are available. We will move on to the next talk, which will also be the final talk, and this will be given by Professor Lutz Frölich, and the title is Treatment in MCI and Early AD, a Changing Landscape. Professor Frölich is a full professor in geriatric psychiatry at the University of Heidelberg and is the head of the Department of Geriatric Psychiatry. Welcome and take it away.
Okay, well, thank you very much, especially to Alzheimer Europe for inviting us all to this symposium, and to Kristian, who organized and set it up so greatly. So my final slide presentation, my final talk in this array is on the treatment options in changing diagnosis in Alzheimer's disease and MCI and early AD. I think really we have a changing landscape, and it will not be less complicated, I would assume. So these are my disclosures. And when we are talking about the new treatment options that are available or not quite available yet in Alzheimer's disease, it is important to reconsider where we are starting from. The current pharmacological treatment in this stage of Alzheimer's disease, which is usually called mild cognitive impairment or MCI, is as yet uncharted, one must say. So there is no evidence actually for an efficacy of antidementive pharmacotherapy for either risk reduction, symptom stabilization, or any of the outcomes that could possibly be chosen in subjects with MCI. Actually, there have been several large trials in the last century, one should say, with cholinesterase inhibitors, and they were grosso modo all negative. I mean, there were sometimes small hints that in subjects who have a particular profile, let's say who are amyloid epsilon 4 variant positive, there might be an effect even at the stage of MCI, but more or less all these trials have shown that in MCI cholinesterase inhibitors, the symptomatic treatment doesn't work. So the practice recommendation is this is a state of risk to progression towards dementia, and thus dementia prevention measures are the ones who should be considered. What is the future or the potential future? We have heard a lot about biomarker-based early diagnosis, which actually is important in the context of therapy because this is a precondition for all future therapies. And we have heard a lot about the burden, the cost, and the availability of all the tools and the application of early diagnosis. So this is a complicated start for treatment. And the treatment itself, which is now being considered, is seen as a disease-modifying treatment in Alzheimer's disease. So the previous cholinesterase inhibitors were all symptomatic in nature. They have stabilized the function of existing neurotransmitter networks. But now we are the new treatments with antibodies. In the particular example here is the aducanumab antibody. They all target the basic pharmacological, the basic pathophysiological mechanisms in Alzheimer's disease. And I will talk about this and the approval process because it's been very complicated and how this fits into the context. And so in the final end, the question really is about the perspectives. What will happen if these antibodies, may it be aducanumab or other of a similar kind, if they come into practice use? And the big question is if the system of medicine is really ready for taking up these changes. So when we talk about current modern molecular treatment of Alzheimer's disease in early stages, it is mainly on amyloid antibodies. It is not exclusively on this, but the four current antibodies, aducanumab, donanemab, gantenerumab, and lecanemab, which had used to be called EAN 2401, are all targeting the amyloid beta peptide at certain epitopes. And this goes in parallel with a specificity of targeting peculiar parts of the amyloid aggregation pathway more towards higher species of aggregated amyloid in fibrils or protofibrils, and also at the site of plaques. So they are very specific antibodies in the context of this complex pathophysiology which is associated and widely described with Alzheimer's disease. And it's only part of it which may be and is considered as the central start for the pathophysiology, but not the whole story. And the story centers around the amyloid cascade hypothesis, which is sort of the narrative is that this is really the specific part of initiating Alzheimer's disease, because from a large protein, which is called APP, peptides are being released, the amyloid beta peptides, which have very unfortunate physicochemical properties. They tend to aggregate and stabilize that in terms of oligomers at first, and then they form plaques, and this initiates a whole array of neuroinflammatory processes around this, which in the final end is connected with neurodegeneration. Then this is the proximate cause, biological cause of the symptoms. So if you inhibit this formation of the peptides, the belief is this will help with the symptoms as well. And this question has been tested with a number of antibodies before, and aducanumab was the first one in this set of anti-amyloid antibodies, which was very peculiar and very innovative in two aspects. The first aspect is that aducanumab produced in a dose-dependent fashion a reduction in the deposition of amyloid in the brain when given to patients over the course of 1 year. So the patients who received the highest dose, which was actually really a high dose in comparison to what has been given before, 10 milligrams per kilogram of body weight in patients, produced the strongest reduction in the amyloid deposition in comparison to placebo patients or in their own baseline situation. And in parallel to these biological effects, there were also dose-dependent effects on the level of specific outcomes, which are usually used in clinical trials in Alzheimer's disease, the clinical dementia rating scale, the sum of their boxes, and the mini-mental state was also an outcome measure. In this fairly small 160 patients around phase 1 clinical trial. So this was a new hope which arose that this antibody was sort of better than the previous antibodies, which also showed some biological effects, but not these clinical measures. And now this led the company to initiate a series of 2 large clinical trials, which jumped directly from the first phase of drug development to phase 3, meaning that in particular, safety assessments were limited and the dose dependency was not really widely worked out. So this was the hope that they could sort of develop this antibody very rapidly. But the whole story, as you can see from this more or less complex slide about the process of the aducanumab phase 3 clinical trials, was quite complicated. And it was hampered by methodological problems and limitations, which were partly produced on the side of the company itself, but also partly produced, and the major actually of this was produced by a decision from the regular authorities with which all the conductants and the setup of the trial had been negotiated in the first place. Because of this limited knowledge on safety profile of these drugs, in the first place, there was a limitation that subjects in the trial were only allowed to receive the highest doses of the compound when they were ApoE4 negative. And after a while, it was seen that the safety profile of this compound seemed to be okay in the beginning. So this block of dosing was relieved in the so-called Protocol Amendment 4, which was implemented in the beginning of 2017, it took a couple of months to really get this into practice. And as you can see here, this had important consequences. So these studies were initially designed to really run in parallel, which means they should start at the same time and they should recruit patients at the same pace until the final recruitment end. But you can see here, as it usually is, that one of the trials was a bit slower and the other one was a bit more rapid in recruiting patients. So there was really a difference in the number of subjects who already started on the dosing in one trial over the other one. And the second methodological problem was that the company in the beginning had decided, after recruitment ending, but while the studies were still starting to really run over the course of 1.5 years, to make a futility analysis. So this is an often used tool, not only to estimate the likelihood of a positive outcome in the later run, but also to consider this in the context of the costs of clinical trials. So if the likelihood is under a certain threshold, then this should be stopped and this saves cost on one side. But it also is an ethical issue because it would, in this case, relieve patients from the burden of being in a clinical trial or clinical trials which were considered to most likely not to produce any positive outcome. So the data were drawn for this futility analysis at the end of 2018, and it took a couple of months to calculate the outcome of the futility analysis. And during this time, the trials were obviously continuing. And the futility analysis, which was calculated, showed that it was unlikely, it appeared unlikely that the trials would deliver a positive clinical outcome. So the studies were stopped. But at this stop time, of course, the data were drawn again. So there was additional data coming up in this. And these data were analyzed in a complicated and different way to reconsider the question if there is a positive outcome or not. This was all done in conjunction with the Food and Drug Administration in the US. So this was a complicated process, and this was by the end of November. These data were sort of made available to the more public, and it showed that there was a likelihood that one trial, it showed that one of the trials came out as positive, actually, even it was interrupted. And the other trial, however, was not. So this was heavily discussed at an open meeting with external advisors from all over, from the United States, actually. And most of the high majority of these advisors said, well, this is not enough to approve this drug as an efficacious treatment for early Alzheimer's disease. So these data were again reconsidered by the FDA. And surprisingly a lot, in June 21 this year, the FDA accepted the data on the basis of a certain conditional approval. And this was not done actually on the basis of clinical data. So this is what I wanted to summarize, how I wanted to summarize the trials. And I just would like to show you some aspects, although this looks really complicated. So the major point of this one positive trial in this type of calculation was on their primary outcome, the CDR sum of the boxes. So there was a 22%, which is fairly small, but significant superiority of the high dose group over the placebo group. And this, and which is clinically always very positive, was accompanied by secondary outcomes, which were all regarded, calculated to be positive, namely the ADAS-Cog and the ADL scale from the ADCS consortium was also both positive. This was not true for the other study. And this had some plausibility because of the lack of parallel running of the trials. And if you if there was sub-analysis of the high dose group within this negative clinical trials, so those subjects who had the opportunity to really receive the highest dose for the longest time required, then this subgroup also was significantly superior over the placebo, but this was a post hoc analysis. So the clinical outcome was unconclusive, and this was one outcome, the major outcome. However, in the analysis, the data from the biological outcome markers looked quite different. So in the subjects who were in both studies, the placebo subjects had a high level of amyloid deposition in brain, and this was measured by amyloid PET. And in the high dose group, this deposition was drastically, significantly reduced in both of these trials. And this was comparable to this first phase 1 study that I had showed you before. So this showed that the drug was actually working on the plaques, and this was producing a long-lasting effect. And most importantly, the biological effect was not only observed on the amyloid level, but also on the level of the tau proteins in the CSF. However, as you can see here, if you look at the numbers in here, these numbers are really very, very small in comparison to the 1,680 subjects in the trial. There were only 28 to 17 subjects per group in the CSF studies. However, the data were very convincing. In the positive, clinically positive study, there was a dose-dependent reduction in so-called downstream markers from phospho-tau and total tau in this one trial, and in the trial which was clinically negative, there was not such a clear dose-dependent change in the downstream biomarkers. This was for the first time that such markers were shown to be positive in a clinical trial context as a result of a drug working. Now, very recently, actually, at the CTAD conference this year in November, another set of biomarkers was coming out and was presented by colleagues from Sweden who had analyzed, Oskar Hansen and his group had analyzed these tau-dependent biomarkers, not in CSF, but in the plasma. And there was a comparable situation to be seen as with a small set of CSF biomarkers, but here in a subset which was a lot larger. So in a total 6,000 samples were analyzed at baseline, at 1 year and a 1.5 year in each of the 2 trials. And you can see here that there is a dose-dependent decrease of the plasma tau biomarkers in those 2 clinical trials, which is comparable to what has been shown in the CSF studies. An additional analysis of these data show that there is also a positive correlation with the reduction in amyloid deposition in the brain, with a reduction in the plasma tau biomarkers, a correlative analysis, and another correlative analysis with some limitation also showed that these reductions in phospho-tau, dose-dependent, depending on the high dose or low dose group, were also correlated with a positive clinical outcome in comparison to placebo. Also quite complicated correlative analysis, which sort of provided further evidence that these data not only showed biological effects, but they correlated to the mechanism of action to the drug and had a relevance for the clinical effects as well. However, one must not forget that the treatment of aducanumab is a complicated one, and it is also a drug which has some tolerability issues. So the most frequent is that changes in the amyloid related imaging abnormalities is most frequent. So 35 of these patients experience some sort of edematous state induced by the drug itself, which is also sometimes accompanied by blood effusion in the brain and clinical symptoms. So this is not only a radiological finding, but in a quarter of the subjects who have this finding in the brain, which only can be demonstrated by MRI in the first place, also had clinical symptoms. And 4% of these clinical symptoms were also quite severe, meaning clouding of consciousness, epileptic seizures, and similar focal neurological symptoms. So this requires a very complicated and frequent MRI monitoring and appropriate clinical management. So the whole story is quite complicated on the methodological part. So the FDA decision to approve this drug, not because of its proven clinical efficacy, but its proven biological effects, was based on accepting that the amyloid changes induced by the drug can be taken as a surrogate outcome marker, meaning that the fact that aducanumab reduces the beta plaques in the brain is reasonably likely to connect it to a prediction of an important benefit to patients. This has been heavily discussed if it's really true. And the other side is that this drug is complicated to apply by repetitive monthly infusion and requires this complex biological based diagnosis. So quite a complicated and uncertain situation still. And the approval of the drug is only based for the United States, not in Europe. Other drugs.
Lutz, apologies, I'm going to have to draw you to a close quickly.
Yes. So other drugs try to follow the same route. So this is quite important. This has important impact on outcome on other drugs under development. And the whole story of Alzheimer's disease is not finished with anti-amyloid antibodies, but will extend also other mechanisms, actions are being discussed. So in summary, these new treatment concepts reside on the idea that they modify the basic pathophysiology of Alzheimer's disease. They have biomarkers as diagnostic basis in the end as a prerequisite. These anti-amyloid approaches are the first sort of wave of molecular treatments which arrive, but they will be accompanied by anti-tau approaches, and many other sort of drugs are under development here. And the combination of such drugs is already being discussed. So the question really is if these complicated molecular antibodies are really sort of a better solution here. And the question really is that they are only approved in the United States and not in Europe so far. So thank you very much for your attention.
Thank you very much, Lutz, for giving this very clear overview of a complicated area, and not least the whole story about aducanumab. And despite the uncertainty and clouding, I think there's still reason to be hopeful. Just to prove that this was a really interesting session, we've all overspent the time allotted to ourselves, but that's how it goes. And we will have to cut this the Q&A session short, unfortunately. But just by wrapping up, I'd like to thank my three co-presenters for joining and really giving a wonderful session. And thank you once again to Alzheimer Europe for inviting us and for organizing not only the symposium, but also this very nice conference. And thank you to all the attendees. Good day and have a nice rest of the conference.